Okay, so thank you very much. I'm not sure if the mic is projecting very well. Very good. My name is Mohamed Jeilan, and thank you for the very kind introduction and for the invitation to come back to Egypt. The last time I was in Egypt was 1979. I left here when I was 4 years old, and it's an exciting 3 days that I'm having over here. I'm here to present a case from Kenya, and unfortunately, just to let you know, one of the memory sticks that was supposed to contain the data for this presentation was left behind in Kenya, and unfortunately some of the images may not project. And what I've done is I've actually decided to invite everybody who hasn't been to Kenya to come and join us, myself and obviously the new president-elect for African Algorithm Association, according to the nomination of our current president, to Nairobi at the end of January. The three of us will be there running a big meeting with the Heart Rhythm Society of the US and the European Heart Rhythm Association. It's the first time Africa has come together to discuss this. We expect more than 200 people to attend, and obviously, hopefully many of you will be coming from Egypt. I'm a resynchronization therapy specialist. I'm not really an electrophysiologist. I do a lot of coronary intervention and also structural intervention. But one of the things that strikes me is that many people don't respond to read CRT, and we've been trying to study this and understand this from detail. And there are usually two reasons why people haven't responded. Either the patient didn't have the synchrony to start with, or they had the synchrony and you failed to resynchronize. Sometimes this is related to a failure of lead placement. In other words, you put the lead in the wrong place, or the activation patterns in the patient's myocardium are multiple. In other words, there's a problem with delay in the posterolateral wall as well as in the anterolateral wall, and just putting one lead may not be sufficient. Sometimes the problem is because you haven't programmed the device appropriately and the patient's gone into atrial fibrillation. And sometimes, as we discussed yesterday, it's related to device time. But I want to talk to you about a particular patient who was 72 years old, presented in 2012, having received CRT and failed to respond. It was getting worse. And we put him through an EP study in order to evaluate whether we should put the lead in a different position. This patient came in, he's got an LV lead in the lateral wall, and he went through a standard EP study to try and look at activation timings and see whether we could shorten the QRS to LV lead placement position 1 year after his original lead. He went through a standard femoral approach with the coronary sinus assessments, and we use something called a Cardima wire, which is a 5 French wire, to get into the lower branches. The patient's blood pressure dropped about 40 minutes into the procedure after we tested 2 potential branches. And the hemodynamics suggested that initially he would be better placed with an LV lead in the anterolateral wall, which he didn't have. But his blood pressure dropped quite dramatically, and he was sweating, and he was quite unwell. And this is what we saw. So this is a catheter in the, it's supposed to loop, but it isn't. It's a catheter in the coronary sinus.
It was looping.
Was it?
Yes, it was looping. I saw it looping.
You need to read real quick.
So this is obviously a perforation of the coronary sinus. How many people have encountered this problem in their experiences in electrophysiologists? Hands up.
How much is it? What out of time? Yeah. This is one case like this.
It's a very dramatic event. Blood pressure shouldn't drop. You're wondering why the patient's got into tachycardia. You can see at the bottom of the screen there's the appearance of a catheter. The patient obviously underwent a pericardial drain insertion. And the strategy for dealing with this has shown that you have to understand that the coronary sinus drains. In other words, when you inject, unlike a coronary artery, the blood is actually coming the opposite direction. So one of the solutions to this includes placing a covered stent. An alternative would be surgery. We decided to try and go for a covered stent strategy. But the question first strikes you is, where should you put the covered stent? If you put the covered stent in the main coronary sinus body, you fail to miss the point. because obviously the blood is draining up the branch and across. So what we had to do was deliver the stent into the branch where we thought the perforation was occurring, and then inflate the stent. And with the covered stent, we were able to achieve a satisfactory result. What I'd like to demonstrate is that you have to double check by a left-sided coronary angiogram in order to determine that you've sealed the problem, because you won't be able to inject forward with the blood draining in the opposite direction. We used a biotronic covered stent, and I was able to confirm satisfactory placement of our lead. The patient then went for an upgrade, and during the upgrade we were able to look at the coronary sinus in detail, and this is a week later. You can see the stent sitting there in the branch of the coronary sinus, and this is the patient who's had a third lead in. So now you can actually place two coronary sinus leads using a wire connector that currently produced by St. Jude, and connect them onto the device like the original CRT devices. In the old days, before anyone had invented a 3-lead device, they actually had to use wire connectors in order to hardwire the technology. So that's the first case. I just wanted to present this case because it's got some nice, interesting images. The case that I actually planned to bring was this case. As I mentioned, unfortunately, the images and the ECGs are on a different hard drive, but I've put together the case. I don't know if anyone can recognize this gentleman up here on the left-hand side.
He's the runner?
His name is Eliud Kipchoge. He managed to run the marathon in less than 2 hours. And Kenyans are known for being long-distance runners. And this gentleman over here was 77 years old. When I first met him, 83-year-olds right now, was 66 and developed chest pain while playing squash. So these are active Kenyan people. He had chest pain while playing squash, and just like everywhere else, the coronary artery disease epidemic is occurring. He underwent coronary angiography, which revealed 3 vessel disease, including LAD, circumflex, and the diagonal. He underwent initially a PCI to the LAD, followed by a PCI to the circumflex, not in Nairobi. He had to travel to Europe to have this done, and then had in-stent restenosis in 2009 and had a drug-coated balloon. But in 2006, 4 years after he initially presented, at the age of 70, again playing squash, he developed dyspnea. The ECG demonstrated atrial fibrillation, and he did not want drugs. He managed to receive treatment for coronary artery disease without drugs, and he wanted percutaneous solutions. So he went to France to have pulmonary vein isolation done. Unfortunately, as sometimes occurs, particularly with persistent AF, he had another episode. Again, he didn't want flecainide. He traveled back to France. They suggested that he should have another 6 months of wait, and they suggested maybe a blanking period. So he rushed. So he came back to Kenya. A few years later, unsatisfied with the situation, he went to Leeds in the UK and underwent a wide area ablation. This was not successful, and by 2010 he needed a third procedure, and he went to Manchester. And unfortunately, the worst thing that can happen when you have AF ablation is you convert it to something like atypical flutter. This gentleman ended up with atypical flutter, which is persistent, the heart rate more than 100. Although it was well tolerated, it really bugged him. And the thing was that he continued to play squash, and he found himself struggling. He came to see me, and I was trying to put all of this together. A man with persistent atrial flutter, not tolerant of drugs, not wanting any drugs, and getting symptoms only when he's playing squash. And we sat down and discussed all the options, a fourth ablation procedure. There's a syndrome that I've come across when people have 3 or 4 ablation procedures called a stiff left atrial syndrome, which is essentially a very bad heart failure variant with get diastolic dysfunction. And I wasn't very keen for him to undergo that. So one of the options we obviously discussed after evaluation of his echo and his coronaries, and the fact that he didn't want to travel and didn't want drugs, was the ablative pace approach. So in other words, we switch him, which would accept atrial arrhythmia, we try and slow his heart rate down by ablation, and put a dual chamber pacemaker. This is what happened. He came a few months later and had the dual chamber pacemaker inserted from the left side, and 3 weeks later he underwent an ablation. The RV lead was placed at the RV apical position, and essentially we programmed to VVIR of 90 beats per minute. The reason why we did 90 beats per minute, and this is new to me as an interventional cardiologist, is because when you program it at a much lower rate, there's a risk of tosalgia points. and there was a big concern that maybe it would actually expose the gentleman to torsades. He had a dramatic improvement. His symptoms settled, and he decided to go and play squash. Now, at this age, many of his squash partners have died, so the main person he plays with is his wife. On the first game, he lost to his wife. The second game, he lost to his wife. In the third game, he lost to his wife. He was very upset about this. He'd never ever lost to his wife. And he came to see me about this. He wanted something done. I can't lose to my wife. So what I decided was to speak to his wife and ask her to let him win. But unfortunately, that wasn't the solution he was after. The truth is actually that he was going into progressive heart failure. 2 weeks later, he had dyspnea and edema. And the echo showed that his ejection fraction was significantly reduced. He's now running with an EF of 20%. And we had moderate to severe mitral regurgitation. All of this obviously related to pacemaker desynchrony. There was a possibility of coronary artery disease, and we had a discussion with him. He's had 3 ablation procedures. He's had a 4th ablation just for the AV node. He's now come in for a pacemaker, and within 6 to 8 weeks, there's a problem with the pacemaker, and he needs an upgrade. We need to look at his coronary arteries. He needs to go under the cath lab table and have some more stuff done. Money's running out because he's retired and he's elderly, and we have to decide whether to go with a CRTP or a CRTD. Hands up the CRTP. Hands up the CRTD. Everybody wants both. Okay, fine. So, obviously, he's got an existing RV lead in place. So, for me, the quickest option would be to upgrade him to a CRTD. I sat down and explained to him that everything would be okay. Let me just switch him to a CRTD. And this is now 6 weeks down the line. I slowed the heart rate down to 70 to try and reduce excessive RV pacing. Although he didn't have another line with him, he told me, "Are you sure I'll be okay with a CRTP?" I said, "Go away, get the money. If you can afford a CRTP, come back." That same night, I got a phone call from his wife. He's collapsed. He came to the hospital confused. We checked his troponin, it wasn't particularly exciting. And on CCU, had 3 episodes of syncope, all of which demonstrated self-limiting VT. Sorry, VF. She had VF runs, which self-limited 3 times. We checked his coronary arteries and they're okay, and obviously now having seen VF, upgraded with CRTB. He had, after that upgrade, no further episodes of VF. The patient's RV lead is not removed, because for us, it would be easier just to go ahead and put the new lead in. We'll put a DF1 lead in the RV and an LV lead in the lateral coronary sinus branch. In a 40-minute procedure. Very quick. In retrospect, I suspect that the reason why he went to the VF was probably this torsades points mechanism where when you slow the heart rate down, which I had done, from 90 to 70, this thing happened. It never happened again. But the story's not over. The next day we check his echo, his MR has disappeared because that happens quite quickly after you put a CRT device. The ejection fraction is still 20%, but within a week, his EF is improved to 40%. This is classical CRT, RV pacing desynchrony. But 2 years later, unfortunately, a blister appears on his skin. He's got leads on the right, on the left side. He's got 3 leads on the left side. He goes and sees another doctor, his local GP, who thinks that this can be managed by antibiotics, who thinks that this can be managed by review of the wound by a plastic surgeon, and he undergoes 4 or 5 different procedures by a plastic surgeon. Once you have a system infection, unfortunately, there isn't a way around it. And eventually the leads eroded. He comes to me and says, "Listen, the leads are eroded." But then his device has actually caused extensive damage to his skin over here. So he has to undergo an externalization of a pacemaker insertion. So what you do is you take a standard pacemaker, you insert it, screw it in, and it's externalized, and then you remove the existing leads, and then upgrade on the other side. So we externalize the device. With the externalization, the ejection fraction dropped very quickly. Removed the original RV PACES lead, the RV DF1 lead, and the LV PACES lead. And a right-sided implant of the CRT device was put in. I've only got 2 more slides, so.
Okay.
After 3 hours of a difficult procedure, of which the RV lead placement took 1 hour, we found that we couldn't find the coronary sinus. So we decided in this case to try and position it in a high septal position using a curved stylet, and managed to place the additional patient's lead in a high septal position. And managed to get a narrow QRS complex. Next day, the echo showed good LV function, good illumination of the MR and his ejection fraction improved. But with 3 years now, we've got a stable patient with a single chamber CRT device in place. He's still playing squash in his 80s. Unfortunately, now he has aortic stenosis. He's undergone all of this: AF ablation, redo AF ablation, AV node ablation, conventional pacemaker insertion, an upgrade to CRTD, a system extraction, a right-sided pacemaker implant, and his replacement. Thank you very much.